¿Puedo compartir mi
Sí, por
pantalla?
supuesto.
Bien, ok. Antes de comenzar, les hablo un poco de dónde vengo yo. Mi nombre es Victoria, soy navegadora de salud del estado de Carolina del Norte. No siempre trabajé en el área de salud pública. En realidad, mi enfoque era relaciones internacionales, un ámbito bastante lejano de lo que ahora hago. Eh, por pasión me volví intérprete médica, solamente voluntaria, siempre me voluntarié y ahí descubrí el amor por las personas y la pasión de luchar, porque en la salud las diferencias y las discriminaciones hacen la diferencia entre la vida y la muerte. Así que ahora me dedico a esto y les voy a compartir la presentación para que podamos ahondar. Comencé hablando en español, pero en realidad la presentación es en inglés, así que voy a cambiar rápidamente al inglés. I'm going to switch very quickly into English. It's a lot of information. Like I said, I am the lead bilingual navigator for the United Language Navigator Program. Just a little bit of our story. The United Language Navigator Program is a program that is funded and created to assist the uninsured population in the state of North Carolina. We are an international company that provides language access services for various industries, but our main focus is healthcare. The United Language Navigator Program was created by language access experts, and the idea behind it was to improve affordability and access to healthcare for communities with languages other than English. We focus mainly on Spanish-speaking communities, but our patients come from different backgrounds and speak different languages. Along with Legal Aid of North Carolina, we are the only program who holds a grant from the Centers for Medicare and Medicaid Services to serve within the state to help individuals as certified navigators, helping people access the Affordable Care Act and Medicaid. So I come here as a navigator, but a lot of people might not know what a navigator for the state of North Carolina does under the framework of the Centers for Medicare and Medicaid Services. Basically, we identify patients' barriers to care. We advocate and work to mitigate health disparities in access to care. And what does that mean? It translates into us being able to help individuals who have any questions about their eligibility for Marketplace and Medicaid. We assist with the applications. We resolve any application-related issues, as well as advocate for people and on their behalf, especially with the Department of Social Services. We guide individuals who have accrued high medical debt, and this is an issue we see very often, and which we'll talk about a little bit more in the next slide. We do fraud escalation. As navigators, we are the only agents that can help individuals who need to open up cases of fraud, and we'll talk about that as well. We also hold health insurance literacy workshops. One of our biggest passions is to approach our community from an educational standpoint. We work on helping individuals through workshops understand how the healthcare system works. It's difficult for us as it is. Imagine for someone who has just arrived. We help individuals in communities who live with chronic illness, how to navigate their health insurance. What happens if they cannot afford a tier 2 or tier 3 medication, or even more, a specialty infusion? If I have an autoimmune condition, how can I access outside help? Or how can I understand why my insurance is charging me the amount that they're charging me, which is usually an astronomical amount for medications that are considered specialty medications. So in the workshops effort, we really try to help people understand, but also help them navigate their particular access to care. And last but not least, we navigate access to care for non-eligible and uninsured populations. We at United Language, when we first received the grant, we quickly learned that if we worked with vulnerable populations, it wasn't enough to know all the rules and policies around Medicaid. We needed to know how to help individuals access care. And that became the core of our program. It's not enough for somebody to be able to access Medicaid. Is whatever you are, whatever place you're in, let us help you establish care with a PCP, establish care with a community health organization. So we support FQHCs, federally qualified health centers and community organizations. We support specific organization goals, being Medicaid unwinding, expansion, open enrollment. We are living a historic moment in North Carolina where a couple of worlds collided, the world of Medicaid unwinding, which was the recertification process of thousands of people that had been used to having Medicaid and not have to recertify. And then we quickly moved on to Medicaid expansion, thank God, because we had been working with a huge gap in our healthcare system of people that made too much for Medicaid, but too little for the marketplace. So we support organizations in screening individuals according to what they're eligible for, helping in the application process, do post-application support, which is usually in our communities one of the most difficult parts, advocating on their behalf, supporting with documentation, troubleshooting problems, especially red tape problems that can happen very easily in DSS offices. And lastly, health insurance literacy, which we had just talked about.
Victoria, puedes hablar más lento porque
Yeah.
es muy difícil. We have a whole hour.
Yeah, okay. Oh, I thought I only had 15 minutes, so I said I have to keep my time. So some of the current barriers and challenges that we see to enrollment are misinformation. So we all know about the public charge fears. We have patients or consumers that have told us that about their concerns to access Medicaid or to apply for programs because they don't want to have their immigration status be risked if they receive benefits. So that's one of the main barriers that we encounter and that we help counteract with education. There's also a lot of confusion about eligibility based on immigration status. It goes from people not knowing that they have access at all to people not understanding what it is that they have a right to access. There are immigration-related fears, especially for undocumented parents of U.S.-born minors. This we see a lot in clinics where we work, parents who do not want a project access, parents who do not want to apply for Medicaid because they themselves are undocumented. So for them to put down their address is like, oh, I'm going to tell the world where I live, and I'm going to undisclose the fact that that I am undocumented. So it's also helping parents understand what their rights are, and especially their rights to privacy, and the fact that neither the Affordable Care Act or Medicaid share any information regarding immigration status. We also, unfortunately, see a lot of bias and unfair treatment for people that seek to apply for Medicaid. This often happens at DSS offices. There are assumptions about immigration status or apprehension about somebody who's undocumented or has refugee status, how difficult it is perceived that an application may be delayed or maybe thoroughly examined by a caseworker because some cases are very complex. There's also the issue of low literacy that we work with quite often. People that do not know how to read or write, or even people that have low document literacy, what we consider to be low document literacy, which means the ability that people have to understand documentation and manage that documentation. This has proved to be very difficult during the unwinding process because DSS offices were counting on sending out letters to individuals so that they could open it and understand that they had to renew and update their information. And there were many scenarios where we encountered people that had been unwinded, and in the worst possible ways. I had a mom with 2 children on suicide watch who went to get care and was told, you're no longer enrolled, they're no longer enrolled in Medicaid. And it ended up being that she had received the letter, but she had never responded to it. She hadn't understood what it was. So these barriers are real. And when I say that it can mean the difference between life and death, I mean it. There's also language barriers, and language barriers deserves a whole section on its own because it's not only the ability to access information in our own language, but we'll talk about it in our next slide. There's also the element of digital literacy and either inaccessibility to technology or the literacy to understand how the technology works. I know that we have gone through great lengths to make the e-pass more accessible, to make it accessible in our language. But ultimately, we have issues with people uploading documentation because, one, they don't know how to upload it. To the what we call the enhancement of the account, which is a process that people have to opt in on. An enhanced e-pass account basically means that people will be able, if they enhance their account, they will be able to access their social worker, communicate with the DSS, update information on income. It's supposed to make the experience more seamless for beneficiaries, yet to be able to enhance an account, the person needs to accept to have their credit history checked, not as an impact in their credit, but as a way to identify their identity and verify it. And a lot of people in our immigrant community don't have any credit history. So they cannot really access or enjoy this benefit that the e-pass system gives them because they don't know, they don't have the credit history, and they also don't know how to navigate it. And as navigators, we are a crucial part in either helping them enable getting an enhanced account, or if they don't have the access to enhance it, navigate them in the process of uploading documentation and getting in touch with the DSS office. Another barrier that we see is high medical debt due to uninsurability, and thank God we have a new program that will be giving incentives to hospitals, which all of the participating hospitals are the main hospitals that are around in North Carolina. But the way that high medical debt due to uninsurability affects enrollment is because people are hesitant to apply for benefits because they feel that they have accrued high debt and hence they won't be allowed to have benefits. And this is very far from the truth because why? Because as a Medicaid beneficiary, you can ask to have up to 3 months before your application, right? You can have medical costs covered for. And the other work that we do as navigators is that we help them understand how they can, the steps that they have to take so that they don't have to live with high medical debt. We navigate patients through financial assistance. We look for programs that can help them with affording healthcare and for programs that specifically deal with medical debt. The other enrollment barrier is confusion on fluctuating and unstable income. Most of our communities work as self-employees. We have a lot of individuals that depend on high seasons, and this is mainly from either construction or landscaping, people in rural areas that tell you, well, I was denied Medicaid because I showed them my pay stubs and it was too much, it was too high. But wait a minute, why don't you show your tax returns? Or if my tax returns last year I reported a lot of money, then let's look at what your income is now. And this causes a lot of confusion and apprehension because it's difficult to hear, no, you make too much, and to look at your life and said, but what do you mean? I am struggling. And it's because a lot of our people do not make stable income on a monthly basis. Another enrollment barrier is the lack of proof of residency and income. Many people share households. Many people rent from others, and many people don't get paid with pay stubs. So it's difficult for them to provide proof of how much I get paid. It is embarrassing to ask my boss, hey, can you give me a letter letting the DSS office know how much I get paid and how often? So as navigators, we walk them through this process and help them gather the information so that they can figure out their pathway to care. And lastly, it's fraud. And fraud is a whole section we're going to talk about because fraud is like COVID, but it's fraud in the sense that it's everywhere. It's in every single state. In North Carolina, it's become more prominent. And what it entails is that there's a lack of understanding of the risks of sharing PII, or in the case of the undocumented population, being improperly signed up for federal benefits. So if I'm being told that, oh, it's okay, you can sign up, nothing is going to happen, we're going to see in a couple of slides what are the risks associated with signing up for benefits when you don't have the eligibility. So let's talk about language access barriers. I wanted to focus on it because, like I said, it's not only the ability to access information in a preferred language, language access, and I believe this because I've been on the field as a medical interpreter. It really lies in the details. And this is where barriers can become humongous. So in terms of Medicaid access and the Affordable Care Act, most of the problems with language access begin post-application. And why do I say that? Because I can fill out an application, right? If I have given all the right circumstances, if I'm digitally savvy, if I know how to fill out a form, I can fill out the application in my language. But afterwards, the part of communicating with the DSS, right? How do I deal with that? And it becomes a huge problem because you see a lot of people that may apply, but a lot of people that end up not getting Medicaid because they get lost in the back and forth with the DSS office. So navigators play a critical role in enabling individuals build a communication bridge with the DSS office. Some of the issues we have is documentation sent does not always reflect the preferred language. So we see people that fill out their application in Spanish, that choose their preferred language, but are getting letters in English. The other factor is complex language. How accessible is the readability of the document? Navigators, we always repeat amongst ourselves that our language has to be very basic because people don't necessarily understand complex language, even in English. I once had an American beneficiary who received a letter that was a determination letter from Medicaid, and it read Medicaid ... adequate. And there was a date in the bottom. And she called me and she said, I have no clue what this means. Do you? And I said, well, we're going to have to call and verify because adequate seems like it's something positive, but it didn't read accepted or approved. It read adequate. So in the complex language that is used, a lot of information can be lost. We have the issues of lack of Spanish-speaking staff at the DSS offices. So we have a lot of caseworkers that don't speak the language and might not bother to get an interpreter, which would be the right protocol and the law, but it's not happening. And the lack of cultural awareness. So we have caseworkers that might doubt, oh, where is this letter coming from? Who this person can claim to be your boss and it might not be your boss. So understanding what are the cultural implications that are common in our community becomes also a part of the language access barrier that people have. So some of the solutions that navigators have is to guide the consumer in a step-by-step approach, especially when gathering, sending, or uploading required documentation. And the step-by-step approach is sometimes it depends on what the literacy of the person is. It can mean sending the person a picture of what they're supposed to be looking for if they don't really know how to read, or it can mean gathering with the person the documentation needed, and then helping the person either send it to the DSS office or offering to help them email it, since many people in our community don't know how to use their emails. The other part is advocating for consumers to obtain documentation in the patient's preferred language. This is very often seen in the Affordable Care Act when it comes to summary of benefits. How do I understand what it is that I'm getting into? And correspondence from the insurance. We also assist consumers with communicating with caseworkers. It is very common to hear, I cannot access, or I haven't been contacted by my caseworkers. So navigators also know how to work around and get to caseworkers. And lastly, educate consumers on language access rights. Interpreters are available and should be requested at any federal facility or medical institution. Okay, so let's talk about how we navigate people in our community through the ACA and Medicaid. Some of the main considerations that we have for immigrant communities is that we pay close attention to the types of verification documents required for each benefit, and if individuals can provide it as proof. And this is especially important because a lot of people can tell you, oh, I'm a refugee or I'm an asylee, but do you have an I-94? Do you have an EAD? Do you have a social security number? So there is a lot of confusion about my status and about the type of document that I have to verify that status, right? Another point is that you have to understand what categories are considered as having a qualified immigration status. Some of these categories might be categories that we don't really think about, like TPS or deferred action status. We usually think, is the person a resident or is the person undocumented, right? No, there are different categories that under the Affordable Care Act are considered qualified immigration status categories. We also have to identify which non-US categories do not have to wait 5 years in order to apply for Medicaid. And this is a big misconception. There are categories of immigration statuses that don't have to wait 5 years, such as refugees, asylees, for example, parolees admitted for more than 1 year, even Venezuelans, which have been seeing a huge increase in people here. If they've been here for a year, they can apply for Medicaid. So it's important to identify which categories can access Medicaid, right? We can also not underestimate emergency Medicaid. We know that undocumented individuals cannot access Medicaid unless it's Medicaid, emergency Medicaid. But emergency Medicaid can be a powerful resource, especially for individuals who have been hospitalized and have to go through life-saving procedures, or patients who need dialysis. For them, it means a lot to have Medicaid, because it means that it's what keeps them alive, right? Another piece of information that is important for navigators to consider is that there are applicants for certain statuses that have access to the Affordable Care Act and the subsidies that are given through the Affordable Care Act, especially if their income is between 100 to 400% of the federal poverty level. U.S. residents, for example, green card holders who have been denied Medicaid due to immigration status because they haven't completed the 5-year bar waiting period, can access ACA advanced premium tax credits. They can even access copay assistance. So this means that these are plans that are almost completely subsidized for. Why? Because premiums are covered, deductibles are capped, out-of-pocket maximums are capped, and copay assistance, there are copay assistance subsidies as well. So these are very low cost and affordable plans that people can have and don't know, because they simply stay with the idea that I need to be here for 5 years in order to receive Medicaid. Huge piece of news. DACA recipients, as of November 1st, will be able to not only access advanced premium tax credits and copay assistance if they are deemed eligible based on their income eligibility criteria. So that's another huge development that we've seen this year. For ages, we've been telling DACAs, no Medicaid, no Affordable Care Act. It seemed like every door was closed for them. And now we're seeing the Affordable Care Act being a source of support for access to care for them. And last is educate the community on ACA insurance and the implications that ACA insurance has. And we'll talk about those implications when we talk about fraud. So I wanted to share this beautiful document that was developed by the North Carolina Justice Center and the Charlotte Center for Legal Advocacy. It's a document that they released not long ago that lists who is eligible for what, depending on their immigration status, and the type of verification documents that they can provide so that they can access those services. DACA has not been updated, but I still encourage you to go to their website and search for the North Carolina Health Insurance Eligibility for Immigrants flyer. Okay, and last but not least, when we help immigrant communities navigate pathways to access to care, also means that we have to help them navigate safety nets for uninsurable or undocumented populations. We always strive to educate consumers on their rights to access healthcare when benefits are not a possibility, and that's through federal qualified health centers. They are a vital and vibrant part of access to care for our community. We also help them connect with their local FQHCs and affordability programs. And this part is very important, because we might tell people, okay, what you should be doing is that you should be connecting to your community health center, and we leave it at that. But the danger with that is that once they go to their FQHC, once they look at what are the requirements for a pay scale, to be part of a pay scale program, they might face barriers. I'll share with you one of my latest cases. A woman who doesn't know how to read, a woman who doesn't know how to write, a woman who doesn't drive and doesn't have transportation. She went to great lengths to get to a clinic. I sat with the patient. I sat with the financial navigator, and lo and behold, she was missing documentation, and she was asked to email it. And she looked at me. She said, "I don't have an email." And she asked, "Can I send it in a text message?" And of course, this is a clinic, they don't accept text messages. And she said, "Oh, what am I going to do? I'm going to have to go back home and I don't have anybody to drive me back." And she was about to give up. I'm glad we have HIPAA regulated and compliant text messages. So I was able to step in and say, well, snap a picture, send it to me, and I'll email it to the financial navigators. So navigators, again, become a critical part of targeting those barriers, because in an ideal world, every undocumented person, and I truly believe this, should have established care with a PCP in a community health setting. Why? Because if they get an upper respiratory infection, they can get antibiotics. If they don't know they're diabetic, they can get their insulin. If they're walking around, and there are many, because one, and I know it because one of our sites is a mobile clinic, there are many people walking around with unbelievable high blood pressure. Well, if I have a PCP, the preventive care part takes care of the possibility of me dying of a heart attack. And lastly, we navigate with them what pay scale programs mean and financial assistance applications. And we see this with individuals who have accrued high medical debt that end up in the ED and then are discharged without a clear understanding of what an emergency Medicaid application is, or individuals that many months have passed by and they're receiving bills in the mail and they're too scared to even call the hospital because I'm not insured and I don't earn enough. As it is, I'm only making enough to buy food and pay for rent. So that's also part of what we do. So let's dive into fraud in the health insurance marketplace. This is a hot topic right now. We're seeing it everywhere. And I'll begin with the basics of what are the protocols that the Centers for Medicare and Medicaid Services has established. They have very rigorous regulations for navigators, CACs, agents, and brokers. Like I said, we have to get certified. And most of our training involves ensuring privacy, security, transparency, and consent for all consumers registered in the marketplace. Agents and brokers who participate in the federal marketplace must obtain consumers' consent. We also have to get consumers' consents prior to assisting them. We have to refrain, and agents have to refrain from marketing or conducting or giving information that is misleading, as well as including misconstrued information in applications. And this is punishable by law. We are required to protect identifiable information and maintain HIPAA compliance like everybody else in the healthcare setting is. So how are immigrants being targeted? We are seeing a lot of people being called incessantly, and I would say in a predatory way. They are being given information that is not accurate regarding their eligibility, especially individuals that have just crossed the border and have received a notice to appear in court, right? And usually these individuals, you can identify them because they will show you an I-862 form or a form that has been stamped as a notice to appear in court. But these documents don't have an approved status because it's just that. It's just a date where the person will have to see a judge. That usually when these applications are filled out for someone who's undocumented, the immigration status and income is modified, and the income is modified to receive not only subsidies, but cost-sharing assistance. And I have a big training that can delve into what this entails, but this is not training only on fraud. So if you need more assistance or if you need your team to be trained, I can also help you with that. People do not receive the accurate information of health insurance literacy and marketplace tax implications. Why? Because Somebody who has a marketplace insurance is someone who will need to file taxes. Why? Because at the end of the year, every single marketplace beneficiary will receive a form that we call the 1095-A form. And it's a form that the IRS sends out where they include the amount of subsidies that the federal government gave them. And what happens with this 1095-A form is that it needs to be reconciled with the amount that the person made during the year. So if in the form I said that I will be making an amount and I was given subsidies for that amount, if that amount happens to be different at the end of the year, then my subsidies need to be reconciled and changed. Another part of fraud is that people are being signed up for more than one marketplace plan. And we often find this in people that have canceled their marketplace plan and soon after find out through the mail that another marketplace plan ID card has been sent. So what are the possible consequences for undocumented fraud victims? People might end up owing premium tax credits if there's this great discrepancy at the time taxes are filed. Legal consequences when seeking U.S. naturalization, Form N-400, which is the form for naturalization, specifically asks if applicants have ever made any misrepresentation to obtain any public benefit in the United States. And owing balances over medical services provided and facing high deductible and out of pocket. So the picture on the left is actually an actual photo of a fraud victim. If you look at it carefully, you will see that if the person wanted to visit a specialist, they would have had to pay $100 per visit after meeting a deductible of $7,000. This is a woman who doesn't work and who has an only child. So you can just imagine her face when I explained what that little car entailed. Going to the ER would have meant 50% of the total cost of the visit after meeting the deductible, which was also $7,000. So a lot of people are getting insurances sent to them. They're being told, it's okay. The government wants to help you. This is part of a, whatever they tell them, this is part of a program to help individuals access healthcare without really knowing what they're getting into. So how do you report a fraud? People can call the health insurance marketplace. Okay, and if the marketplace confirms that the insurance was not consented to, and if the plan was not used, they can ask a marketplace representative to cancel or terminate any active coverage. I highly suggest that you contact an Affordable Care Act health insurance navigator, which would be either navigators in the Legal Aid Consortium or United Language to assist with reporting the enrollment without consent to the Centers for Medicare and Medicaid Services and to submit an agent fraud claim. The Centers for Medicare and Medicaid Services have a complex case help center, which will investigate the claim. Only navigators can submit this type of form, and the navigator and the consumer can be contacted as part of an investigation. The consumer later is told the outcome and the next steps, and depending on the outcomes, they might receive an amended 1095-A, which will help them resolve any pending subsidies that have been granted to them. And unfortunately, even if the consumer was unaware, sometimes they may owe IRS money for premium tax credits received. It is also recommended that an agent fraud claim is filed with the Department of Insurance. Navigators can assist with this process. However, in our community, I haven't had much luck. People are very afraid of contacting the NC Department of Insurance and letting them know what happened to them because they're afraid due to their immigration status. And of course, if it is believed that the consumer's identity has been stolen, it should be reported to identitytheft.gov. So how do you find a navigator in your area? You can either tell people that when they file their Medicaid application on the page, they can access our calendars and schedule an appointment with us, or you can direct them to getcoveredamerica.org. There's a version in Spanish, which I've included a QR code, and also in English. And this is my contact information if you wish to ask me any questions.